I think internists, we're all wondering, who should we test? When should we test? When does it actually change management? Because I'm sure we've all run into the situation where you test when you didn't need to, and then you found something you weren't hoping to find.
Well, your comment actually brings me right to cut to the chase. You have to know what you want to do with the results and how to use the results for thrombophilia testing before you actually order the tests. So, of all the US patient population, less than 10% will have an identifiable inherited thrombophilia. So, we're talking very, very low level, yet a lot of money spent on testing. And what do these do, right? So the point mutations in factor V Leiden and prothrombin gene mutation make it easier for you to get a clot because you can't shut off factor 5A, active 5. And there's more substrate is our hand waving theory for why the prothrombin gene mutation, which occurs early on in the promoter region, just produces more prothrombin. The natural anticoagulants, there's over 200 known mutations for each one. So protein C and protein S, we don't look for the gene sequence. We actually need to get activity levels and antigen levels. And those have some of their own caveats with regard to testing. But that's really it. Those are the 5 tests that we have for inherited thrombophilia. They make it easier for people to get a clot and get a clot of thrombosis, particularly deep vein thrombosis, at an earlier age than if people did not have one of those mutations. But there are not a lot of data that about the utility of testing. It hasn't really been shown to benefit patients. We do think there's some unique circumstances where if multiple family members at a young age have had a thrombosis and you have like a young woman looking at using combination estrogen, progesterone, oral contraceptives, there may be benefit to knowing, but that's in the setting of having flags for testing in the first place. Whereas it's clearly been shown not only not cost effective, right? Because let's not even focus on cost. The usefulness of testing all women contemplating combination oral contraceptives is just time and testing prohibitive because the number that are positive is very, very low. So outside of that situation, people test to maybe explain why someone had a thrombosis, but it should not be used to guide duration of treatment. In other words, if you had your appendix out and you developed a DVT and someone tested you and you happen to have factor V Leiden, that does not mean that you need lifelong anticoagulation, right? Had a clearly surgically provoked and likely inflammation provoked as well, thrombotic event that does not need more than 3 to 6 months of anticoagulation. So there are a lot of nuances to the testing. We try to encourage people not to test during an acute clot episode for inherited thrombophilia because it's not going to change your immediate management. The only time I think it is helpful is for women of childbearing age who might use estrogen, progesterone, combination oral contraceptive pills, and possibly during pregnancy. So there are a lot of people that I don't test who come to my clinic.